Good evening, our dear friends and viewers, our CEC members from Egypt and all over the world. We're glad to announce the second wave of the Best of EC 2021. This second wave will involve two sections. The first section will be discussing the heart failure guidelines, which were updated by the European Society of Cardiology in 2021. And this will be presented by Professor Karim Mahmoud, Associate Professor of Cardiology at Cairo University. And then this will be followed by four of the most interesting trials that were presented also in the ESC Congress. And this will be presented by Professor Amr Youssef, Lecturer of Cardiology at Cairo University. So enough for the introduction now, and let's go to action. So Professor Karim, the floor is yours.
Thank you, my dear friend, Mohammed. Good afternoon, everyone. This is an update of heart failure guideline that was published in the last ACC 2021. What we are expecting in this lecture is to review and the recent updates in heart failure guidelines. There are many new concepts in heart failure management that we are going to mention them in this lecture. So this lecture will be through a question and answer of different aspects of ACC heart failure guideline. So to start, this is the first question of how would we define heart failure according to ejection fraction. And as the previous guideline, we have three categories of heart failure with reduced ejection fraction, heart failure with mid-range, and heart failure with preserved ejection fraction. And the definition depends on the level of ejection fraction. So if it is less than 40%, it would be reduced. More than 50% would be preserved. And if it's between 41 and 49, we have a new term, which is heart failure with mildly reduced ejection fraction instead of heart failure with mid-range ejection fraction. And going to the next question, which is how would we diagnose chronic heart failure patients? And if we have patient that is suspected to have heart failure based on risk factors, symptoms, and or signs, and abnormal ECG, the next best step is to do natriuretic peptide. Depending on NT-proBNP, more than 125 picogram per milliliter, or BNP more than 35 picogram per milliliter, this will diagnose a heart failure. However, if the heart failure is strongly suspected despite a normal natriuretic peptide, or if natriuretic peptide are not available, we should go to the echocardiography, and if we have abnormal findings, this also will diagnose a heart failure. A clinical diagnosis, natriuretic peptide, and echocardiography, in most of cases, we would reach a diagnosis of heart failure, and we need this routine investigation, which are chest X-ray, routine labs, CBC, urea and creatinine, electrolytes, thyroid function, fasting blood glucose and hemoglobin A1C, lipid profile, iron profile, mainly transferrin saturation and ferritin. So this is the basic lab that should be done for all patients with heart failure. But there are other specific tests for heart failure patients that I'm going to mention. The first one is the cardiac magnetic resonance. We will do the cardiac magnetic resonance if the myocardial structure and function with poor echocardiographic window. So it's a class 1 to do cardiac MRI. If we need an information on tissue characterization, especially in myocarditis and cardiomyopathies, and to differentiate between ischemic cardiomyopathy and non-ischemic cardiomyopathy, mainly through the distribution of late gadolinium enhancement. The other test is invasive coronary angiography. We will do coronary angiography if the patient had angina despite medical treatment or symptomatic ventricular arrhythmia. And in cases with heart failure with reduced ejection fraction with intermediate to high pretest probability of coronary artery disease and positive non-invasive stress test. The third is non-invasive tests, meaning CT, SPECT, vitamin echocardiography, and the most important among them is CT that should be done in low to intermediate patient with pretest probability of coronary artery disease or another equivocal non-invasive stress test. And we have now all know that other non-invasive tests for assessment of ischemia and viability have the class 2B recommendation in different guidelines. Cardiopulmonary exercise test is very important, especially before heart transplantation and or mechanical circulatory support. And also to optimize exercise training if the patient wants to start exercise rehabilitation, he should have a cardiopulmonary exercise test, and it can also identify cause of dyspnea and or exercise intolerance among patients with heart failure. Right heart catheterization has an important role in the new guidelines. It should be done before heart transplantation and or mechanical circulatory support. And in other forms of heart failure due to constrictive pericarditis, restrictive cardiomyopathy, congenital heart disease, and high output heart failure. In patients with probable pulmonary hypertension by echo, the right heart cath should be done to confirm diagnosis and assess reversibility before correction of valve or structural heart disease. And in some selected cases of HFpEF, in which diagnosis may be not very clear. The final specific test is endomyocardial biopsy that should be done in patients with rapidly progressive heart failure despite medical treatment when there is a probable diagnosis such as giant cell myocarditis. The next section we will discuss the new advances in heart failure with reduced ejection fraction, starting how would we treat patients with HFrEF. And we have a new algorithm for management of patients with HFrEF, and the treatment, or we have a new concept that the treatment should be depend on the phenotypes of heart failure. So to start, we have a 4-pillar to reduce the mortality, and it should be given to all patients, either ACE inhibitor or ARNI, together with beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitor. Now it's a class 1. All of these drugs are class 1 to be given in patients with heart failure. And if the patient has volume overload, this patient should receive diuretics. And according, if the patient have left bundle branch block more than 150 milliseconds with sinus risk, he should have a CRT, either pacing or defibrillator. And if the left bundle within 130 to 149 milliseconds or non-left bundle more than 150 milliseconds, also this patient can benefit from CRT either with or without defibrillator. In the patient with ischemic etiology and reduced ejection fraction without conduction defect, ICD should be implemented, and also in patients with non-ischemic etiology but with a lower grade of evidence. In the patient with atrial fibrillations, anticoagulation is very important. And for rate control, we can give digoxin or do a pulmonary vein isolation if we want to restore the rhythm in atrial fibrillation. CABG is still the first option in patients with coronary artery disease and heart failure. And we should screen patients for iron deficiency and treat with ferric carboxymaltose, which is the first option in patients with iron deficiency in heart failure. Valvular lesion was elegantly discussed by Dr. Ahmed Farid in the last webinar. And in patients with aortic stenosis, he should have SAVR or TAVR. Mitral regurgitation, if we can do a mitral valve repair, this would be a very good option. In the patient with a heart rate more than 70 beats per minute, they should receive ivabradine, and the black race they should have hydrazine isorbide dinitrate, as this was associated with a reduction of mortality. And ARB should be used if the patient is intolerant to ACE or ARB. For advanced heart failure patient, we can choose between heart transplantation, mechanical circulatory support as a bridge or as a long term. And for all heart failure patients, we should give them the chance for exercise rehabilitation and also for multidisciplinary disease management. Here is the brand new recommendation is to use the DABA or empagliflozin to reduce heart failure hospitalization and mortality. This is as a class 1. And there is a weight in worsening heart failure on top of medical treatment to reduce heart failure hospitalization and cardiovascular mortality as a class 2B. So these two class agents have a new recommendation in these guidelines. Going to the next category, which is heart failure with mildly reduced ejection fraction. Diuretic is a class 1 to reduce the symptom of overload. And we can use all the drugs of heart failure with reduced ejection fraction, but with a class 2B level of urgency to reduce the risk of hospitalization and death. We are talking here about ACE inhibitor, ARB, beta blocker, mineralocorticoid receptor antagonist, and ARB. Regarding the HIF, no more news in these guidelines. Diuretic is still the mainstay of treatment, and treatment of comorbidities is still also very important in management of these patients. However, I believe the coming years will give us a good news regarding the management of these patients. There is a new term, which is a multidisciplinary management of chronic heart failure patients. And we should prevent heart failure before happening by treating hypertensive patients, by giving statin for patients with cardiovascular disease and high-risk cardiovascular disease, by giving the SGLT2 inhibitor for patients with diabetes mellitus and cardiovascular disease or high-risk cardiovascular disease. And we should counsel all patients against sedentary life, obesity, smoking, and alcohol abuse. So what are the other non-pharmacological measurements for management of chronic heart failure? This is from the guidelines. We should optimize the management. And this means lifestyle, pharmacological, and device. And we should emphasize on the self-care and symptom control. If the patient observes a new symptoms, he should seek medical advice, and he may increase the diuretic dose for himself. We should provide a psychosocial support for the patient and his family. We should give the patient idea about how to follow up after discharge and how to have an easy access to healthcare. And we should explain, we should assess any unexplained change in the weight, functional status, and the quality of life, and give the patient advanced treatment option if available, such as mechanical circulatory support and heart transplantation. And this is another general measure. The vaccination is very important, talking about influenza and pneumococcal vaccination. Maybe COVID vaccination may be added in the next guidelines. The supervised exercise-based cardiac rehabilitation also is very important, as previously mentioned. And the monitoring, talking about non-invasive home telemonitoring and pulmonary artery pressure monitoring, can be done for a selected type of patient. Moving into the patient with advanced heart failure, this patient with poor prognosis, how would we manage these patients? We should first define what are the patients with advanced heart failure. Those are the patients with persistent symptoms and the patient with severe cardiac dysfunction, defined as left ventricular ejection fraction less than 30%, or isolated right ventricular failure, or non-operable severe valvular abnormalities or congenital abnormalities, or persistently high natriuretic peptide or severe diastolic dysfunction. Also, there is the patient with episodes of systemic or pulmonary venous congestion or low output states, and severe impairment of exercise capacity. So all of the following criteria must be present to define the patient as having advanced heart failure. And if so, we can give this patient a long-term mechanical circulatory support, provided he will have a good compliance, appropriate capacity for device handling, and psychosocial support. This device can be provided as a long-term for the patient not eligible for heart transplantation or as a bridge for another patient before heart transplantation. And heart transplantation is recommended in other patients with heart failure refractory to the medical device therapy. Other management for patients with advanced heart failure, renal replacement therapy can be introduced for the patient with refractory volume overload or end-stage renal disease, or ultrafiltration also with a lower class of evidence. And some patients we can introduce a continuous inotropes or vasopressors as a bridge to mechanical circulatory support or heart transplantation. Acute heart failure is very nice topic in the new heart failure guidelines, and we have a different section of heart failure, different classes. There is a different classes in this topic. We have the patient with acute decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. So how would we manage this patient with acute heart failure? This is the first patient with acute decompensated heart failure. For example, a patient with known ejection fraction of 35%, worsening shortness of breath and lower limb edema over the last 10 days. We should start by asking, is there hypoperfusion? If no, we should start with loop diuretic as a class 1, and if the patient not responded to the loop diuretics, we should increase the dose or use a combination diuretics. And if we reach to the state of diuretic resistance or end-stage renal disease, renal replacement therapy can be introduced. If the patient has hypoperfusion, we should give him also loop diuretics in association with inotropes. And if not responded, we should give vasopressors. And again, if not responded, we can introduce mechanical circulatory support and or renal replacement therapy. And the final step will be medical treatment optimization as previously mentioned. Other presentation is acute pulmonary edema, is a known patient with hypertension with rapidly progressive shortness of breath, and his blood pressure on presentation was 200/130 millimeter mercury. We should provide this patient with oxygen and ventilation, and again ask if is there hypoperfusion. If not, we should see the systolic blood pressure. If more than 110 millimeter mercury, we can use loop diuretics and or vasodilator. If less, we should use only loop diuretics. And if not responded to the above, we should proceed to renal replacement therapy and or mechanical circulatory support. However, if there is hypoperfusion, this patient should have again loop diuretics, inotropes, vasopressors, and mechanical circulatory support and renal replacement therapy if not responded, and reaching to medical treatment optimization on discharge. The third category in the acute heart failure is a patient with isolated right ventricular failure, a patient with known pulmonary hypertension with progressive lower limb edema and ascites. We should exclude in the patient with isolated right ventricular failure the acute coronary syndrome and pulmonary embolism, as this can be the cause of the acute heart failure, acute right side heart failure, and ask ourselves about the fluid stimulus. If the patient is congested, we should use loop diuretics. If he is hypoperfused, we should combine this with inotropes and the vasopressors. And if not responded, we should add renal replacement therapy or right ventricular assist device instead of mechanical circulatory support or left ventricular assist device. However, if the patient is not congested, we should give him fluid. And again, if hypoperfused, inotropes and the vasopressors going into renal replacement therapy or RVD if not responded. And again, medical treatment optimization is the final step. The fourth category in the acute heart failure is a cardiogenic shock. For example, a patient with ejection fraction is 20%, presenting with shortness of breath, lower limb edema, and hypotension with a blood pressure of 80/50. The SHAMP-8 is the first step, meaning we should exclude the causes of cardiogenic shock, such as coronary disease, hypertension, arrhythmia, mechanical complication, pulmonary embolism, infection, and if these all are excluded, we should give the patient all the available methods for helping with oxygen and ventilation, inotropes and vasopressors, and short-term mechanical circulatory support and renal replacement therapy, reaching into medical treatment optimization. Diuretic therapy management was mentioned also in the guidelines, and this was very nice. So we have the patient with acute heart failure presented on loop diuretics. If yes, we should give the patient 1 to 2 times his oral dose IV. If not, we should give the patient more than 20 to 40 milligram IV furosemide. So we will ask the patient if he is in oral loop diuretics. If yes, we will increase the dose. If not, we will start 20 to 40 milligram IV furosemide. And we will monitor this patient with 2 simple methods. The first one is urinary spot sodium after 2 hours. And the target would be 50 to 70 milliequivalent per liter. And urine output after 6 hours, and the target is 100 to 150 milliliter per hour. If the patient achieves this dose, so we will repeat the IV dose every 12 hours. If not, we will double the dose and searching again for the above target. If the patient reaches the target, we will continue the diuretics till decongestion. If not, we will use a combination diuretics, talking about xyl diuretics, metolazone, or acetazolamide. And for all of these patients, we should check serum creatinine and electrolytes at least every 24 hours. And remember, on charge of patients with acute heart failure, to exclude signs of congestion, optimize oral medical treatment, and do early follow-up at 1 to 2 weeks. So we finished this acute heart failure, and we mentioned the chronic heart failure with different categories, and advanced heart failure, and how to manage patients with acute heart failure. In the next section, we will mention some cardiovascular comorbidities, and I choose here to mention how to treat patients with atrial fibrillation in patients with HFrEF and chronic heart failure. The anticoagulation is a mainstay. Class 1, if the Shad-Vasc score is 2 or more in men or 3 or more in women, and the class 2A, if it is 1 or more in men and 2 or more in women. And we should treat the target, meaning hypothyroidism, COPD, infection that cause or increase atrial fibrillation in these patients. And we should also optimize heart failure therapy as mentioned previously. This is regarding the anticoagulation. Regarding the rate control, if the patient has hemodynamic instability, we should start with external cardioversion, and if the sinus rhythm is regained, so we can continue to have this sinus rhythm by doing pulmonary vein ablation or amiodarone maintenance. But if the patient is still in atrial fibrillation, we can continue in rate control. And if the patient has no hemodynamic instability, we can continue with rate control, and the option of rate control is beta blocker, digoxin, or amiodarone. If still have symptoms, we can go to rate control with pulmonary vein ablation, amiodarone, or at least external cardioversion. And the last resort, if all of the above failed, we can do AV nodal ablation and implantation of CRT. Regarding the patient, this is another cardiovascular comorbidity, which is the chronic coronary syndrome in patients with heart failure. Regarding the medical treatment, beta blocker should be started or must be started in all of these patients if the patient continues to have symptoms. So we will examine the heart rate and the ECG. If the heart rate is more than 70 beats per minute and the sinus risk, we can give ivabradine. And if not, the heart rate less than 70 and or atrial fibrillation, we can give other drugs that has class 2B, such as trimetazidine, ranitidine, nicorandil nitrates, or calcium channel blocker as fildopine or amlodipine. And it's not recommended at all to use diltiazem or verapamil as non-dihydropyridine calcium channel blocker in these patients. Regarding revascularization, CABG is still the first option, especially if this patient has diabetes mellitus and multivessel disease, and VCI can be introduced, especially in the patient with left ventricular assist device or as alternative to CABG. And the coronary vascularization will depend on the suitable anatomy, the risk-benefit ratio, the presence or absence of comorbidities, life expectancy, and patient perspective if he agreed to do CABG or PCI. Moving into non-cardiovascular comorbidities, I choose also diabetes mellitus. Why? Because we have a very important drug in the diabetic patient now, which is the SGLT2 inhibitors. These drugs should be given to prevent and also to treat patients with heart failure to reduce morbidity and mortality. And we should also, as we mentioned above, to screen patients with heart failure for iron deficiency anemia. This is very important, and all patients with heart failure should be periodically screened for anemia and iron deficiency anemia. And when to give the ferric carboxymaltose, if we have ferritin, serum ferritin less than 100 nanogram per milliliter, or serum ferritin between 100 to 299 nanogram per milliliter plus transferrin saturation less than 20%. So two conditions to give ferric carboxymaltose is to have serum ferritin less than 100 nanogram per milliliter. The second condition, if the serum ferritin between 100 and 299, we should have transferrin saturation less than 20%. And the third non-cardiovascular comorbidity is the cancer patient. And the cancer patient with heart failure represent a clinically challenging situation. And guidelines recommend that all cancer patients should have a baseline cardiovascular risk assessment. And the patient with increased risk of cardiotoxicity are those patients with history or risk factor of cardiovascular disease, previous cardiotoxicity, or previous cardiotoxic drugs. And in the patient receiving anthracyclines, these patients should receive ACE inhibitor and beta blocker, preferably carvedilol, if they develop LV systolic dysfunction, defined as drop of left ventricular ejection fraction 10% or more to a value less than 50%. This is the last part of this lecture. I select to add it as an example of update in the management of cardiomyopathy, which is cardiac amyloidosis. We have an update and also a position statement of how to deal with patients with cardiac amyloidosis. So we have what is called red flag of cardiac amyloidosis as general, and these red flags are some of them are extracardiac and some of them are cardiac. Regarding the extracardiac, these are the peripheral neuropathy and dysautonomia, skin bruising, macroglossia, deafness, bilateral carpal tunnel syndrome, ruptured biceps tendons, renal impairment, proteinuria, or family history of amyloidosis. And regarding the cardiac red flags, we have the clinical suspicion with hypotension in the previously hypertensive patient. If the ECG showed low voltage and the conduction defect, The labs with elevated NT-proBNP in this concordance with the degree of heart failure or persistently elevated troponin. In the echo, when we have a granular sparkling of the myocardium, right ventricular hypertrophy, pericardial effusion, or reduced longitudinal strain with apical sparing, and the cardiac magnetic resonance with subendocardial late gadolinium enhancement, increased extracellular volume extracellular volume, and increased T1 time. So how to manage these patients, how to diagnose and how to manage these patients. We have a patient with suspected cardiac amyloidosis based on a patient with heart failure and LV wall thickness of 12 millimeter or more, and his age more than 65, or at least one of the red flags that were previously mentioned. The most two important investigation for this patient are the hematological examination using the free light chain assay and serum and urine protein electrophoresis with immunofixation. And the second is the technetium with SPECT for the myocardium. If both abnormal if both abnormal, there is something wrong, and we need to do histological confirmation, usually cardiac, through endomyocardial biopsy. However, if all normal, if both are normal, amyloidosis can be excluded safely. So this for differentiation between AL amyloidosis and ATTR amyloidosis. If the patient have abnormal hematology, he mostly will have AL amyloidosis. And if the patient is abnormal SPECT, he mostly will have ATTR amyloidosis. So if the patient have abnormal hematology with no myocardial uptake, for exclusion of cardiac amyloidosis, we should do cardiac magnetic resonance. If negative, we can exclude cardiac amyloidosis. However, if positive, we should go to histological confirmation with endomyocardial biopsy or extracardiac biopsy, such as abdominal fat biopsy. But if the patient have a normal hematology with a mild degree of abnormality of on SPECT, this patient also should have a histological confirmation using endomyocardial biopsy or abdominal fat biopsy. If the patient have normal hematology with a higher grade of uptake on the SPECT, this would diagnose ATTR amyloidosis, and this patient should be receive the new drugs that have a class 1 recommendation of the reduction of morbidity and mortality in patients with cardiac amyloidosis, which is tafamidis, which act on stabilization of amyloid fibers. The other drugs that can given and can be considered is the patisiran or inotricin for ATTR and the patient with polyneuropathy. So in patient with cardiac amyloidosis, this patient, for conclusion, should have a hematology examination and should have a technetium with SPECT examination to know which type of amyloidosis. Is it AL amyloidosis or ATTR amyloidosis? And don't forget about the new drug, the tafamidis, that has a class 1 in the patient with ATTR amyloidosis. So to conclude, we mentioned some concept in patient with heart failure. For example, the patient with heart failure with mildly reduced ejection fraction, we define them and we show the new treatment for them. We mentioned the treatment algorithm for patients with heart failure with reduced ejection fraction and how we depend on the different phenotypes for modification of the treatment. We mentioned the modified classification of acute heart failure and the four classes of acute heart failure. We mentioned that some of cardiovascular and non-cardiovascular comorbidities. And for example, of cardiomyopathy, we have some comments on amyloidosis and how to diagnose it and treat it. And thank you. back to Haytham and Zahra.
Thank you so much, dear Karim. This is an elegant presentation as usual. For me, or for my opinion, there are many new concepts and drugs introduced in these guidelines, especially in two entities. The one is the unusual drugs treating hypertension, like ARNI and SGLT2 inhibitors in the treatment of heart failure, and also the new vasodilators like vericiguate used to treat hypertension. This is one entity. And the other entity is the emphasization on the iron deficiency anemia, which is very important here in Egypt because we have an endemic iron deficiency anemia in Egypt. So to highlight the importance of detection and treatment of iron deficiency anemia and its relation to the heart failure patient is very, very important, because many of our patients were treated with the conventional treatment of heart failure without taking into consideration their anemia, and this reflected into not a very successful treatment of their condition. So I think these are the two main important topics in these guidelines so far. So my question to you, by these all recommendations, especially in diagnosis of heart failure and in the treatment of heart failure, what's your opinion about the increasing use of cardiac MRI or CMR in various heart failure treatments? Do this modality will take another privilege, especially in patients with mild reduced ejection fraction and the gray zone between the mild reduced ejection fraction and the HFF?
I believe cardiac MRI is an excellent test. However, it's a test that it can answer the unanswered question. So if we have a question about the diagnosis and what is the etiology of heart failure, and this is not apparent in other similar investigations such as echocardiography, we can go to cardiac magnetic resonance. If we have a question about prognosis, in some cases, how much of fibrosis, we can go cardiac magnetic resonance. The most important use of cardiac magnetic resonance is the differentiation between ischemic and non-ischemic cardiomyopathy, and also in the infiltrative cardiomyopathy and restrictive cardiomyopathy, it's the gold standard test. If you want to have information about the right ventricular volume and the ejection fraction, especially in the patient with adult congenital or heart disease, I think cardiac magnetic resonance is also the gold standard. So many use nowadays in management of patients with heart failure for regarding diagnosis and also regarding prognosis.
I totally agree. Another question to you that which is logic, that all the guidelines stated that we will reach finally the state of non-congestion of our patient before starting the conventional treatment, especially in the four entities of acute heart failure. And in the algorithm that you elegantly showed of how to escalate the diuresis of our patient. They stated lastly in all these algorithms that the patient is not congested. We can discharge the patient or engage him in the regular follow-up. Do the guidelines mentioned how can we state that this patient is not congested or he's dry now by the common description of us as a physician?
I think it's maybe it's mentioned in the guidelines, but if we look to the term of euvolumic patient, this means decreasing symptoms of breathlessness and decreasing signs of overload such as lower limb edema and ascites. If we have also the availability to use the natriuretic peptide for the follow-up, this can give us an idea if it's reducing. This means also that we have a good decongestion of this patient. However, also the decongestion, the good signs of decongestion, as mentioned by the guidelines, is achieving a good urine output at earlier doses of diuretics, together with good urinary sodium that can be done very easily and can be repeated as much as needed to detect the good diuretic dose.
So we must not depend only on the clinical picture of the patient.
Regarding the use of diuretics, the guidelines mentioned that we should, of course, the urine output is a clinical. I will consider it as a clinical sign of improvement. But the urinary sodium is a laboratory marker, and it's an easy laboratory marker that can be done. It's not very hard, and it can be done almost in all ICU. So we should have this concept now in our mind to depend on urinary sodium spots to monitor our patients.
Okay. Another entity is the rehabilitation engagement programs, which is now becoming a must.
Yes.
In the treatment of all patients with heart failure.
Yes.
I think now we must dedicate some of our time to spend it with the patient that is discharged or going to be discharged, to taught him and to engage him in cardiac rehabilitation. I think this is now not a luxury anymore.
Yes, this is because the exercise is not for, as you mentioned, not a luxury. Exercise is associated with improved outcome, improved the quality of life. The patient that will return to sedentary life is expected to have a poorer outcome on long-term follow-up. So to educate this patient about exercise and tell him how to follow up, and how to go to an exercise program rehabilitation, I believe it's now, as you mentioned, a must in all centers that wants to be a center of excellence in managing heart failure.
Okay, one last comment is now the presence of a class 1 drug to treat amyloidosis in order to decrease the morbidity and mortality. Cardiac amyloidosis was thought for a long time that this is a terminal disease with no hope for the patient, especially that it's usually diagnosed in a late stage and not in early stage. So I think it's encouraging to have a medication that tends to decrease the morbidity and mortality in these patients, especially with the algorithm you've mentioned to early detect if this patient is having an amyloidosis or not.
Yes, I admire the position statement of cardiac amyloidosis and also the mention of guidelines for this very useful algorithm. To be mentioned now, previously, if we had a case of amyloidosis, we go to do maybe cardiac MRI, maybe hematology, maybe send him to a hematologist. However, we have now a footprint how to manage, how to diagnose these patients at start, and to classify these patients to continue his management with hematology if he is AL amyloidosis, if he is abnormal hematology, continuing with hematologist, meaning that this patient will receive chemotherapy and stem cell transplantation, or this patient would have a treatment for ATTR, which is very common and very undiagnosed in these patients. To receive these drugs is still is very expensive. However, it can give hope for these type of patients.
Okay, do Zahran or Amr have questions?
شكرا دكتور كريم على المحاضرة الجميلة، ربنا يخلي حضرتك، يعني حضرتك لميت الموضوع بطريقة جميلة جدا. أنا عن نفسي مش عندي أسئلة. نشوف دكتور زهران.
If not, we can proceed to your lecture, Amr.
Okay.
We are very enthusiastic to hear you and to hear the new trials that mentioned in ACC guidelines.
Okay.
So I'd like to introduce my dear friend, Dr. Amr Youssef, the lecturer of cardiology at Cairo University. He is going to discuss two important trials in ACC guidelines, the Emperor Preserved guidelines and the FIGARO DKD and the FIDELITY Bold trials. So please, Amr, share your screen.
Okay, Dr. Karim, thank you. Good afternoon, dear colleagues. My presentation is divided in two sections. The first section carries a title, New Hope for Diabetic Kidney Disease Patients. We'll start with a background. As we all know that 1/3 of the patients with diabetes mellitus develop diabetic kidney disease, and this has been considered the leading cause of end-stage renal disease. The development of kidney disease in patients with diabetes has been associated with increased risk of cardiovascular disease. So the European Society of Cardiology guidelines for management of diabetes had recommended the control of hyperglycemia and blood pressure, along with the blockade of the renin-angiotensin being the key element for prevention and treatment of diabetic kidney disease. And the evidence of this came from the primary prevention of diabetic kidney disease from several randomized trials, Benedict, that had randomized patients to trandopril verapamil versus trandopril alone versus placebo, and another advanced trial in 2007 that had randomized patients to perindopril indapamide versus placebo, and the roadmap trial in 2011 that had randomized patients to olmesartan. And all these trials concluded that therapies with angiotensin converting enzymes or ARBs in hypertensive type 2 diabetes has been associated with a significant reduction of the microalbuminuric risk. What about the secondary prevention of diabetic kidney disease? Several randomized controlled trials also in the form of IRMA-2 trial in 2001 and IDNT, which both had randomized patients to irbesartan versus placebo, and the RENAL trial in 2011 randomizing the patient to losartan, and both trials showed that in hypertensive type 2 diabetes mellitus patient with established diabetic kidney disease in the form of proteinuria more than 500 to 1000 milliliter per minute, or creatinine ranging from 1 to 3 milligram per deciliter has been associated with reduction of the risk of the end-stage renal disease. The question now, is this enough for a patient with diabetic kidney disease? These strategies slow but do not prevent the diabetic kidney disease progression in many patients, and this highlights the need for a new renal protective therapy. Before going and thinking of another new renal protective therapy, we must know the drivers of the diabetic kidney disease. It has been considered that it is the interplay of several pathophysiology, including the inflammation, hyperglycemia, and hemodynamic dysregulation. After tackling the diabetes and the hyperglycemia and the inflammation and hemodynamic dysregulation with SGLT2 and the other oral hypoglycemic drug, and blocking the renin-angiotensin-aldosterone system, new drugs, non-steroidal mineralocorticoid receptor antagonists, came to play a role in the prevention of diabetic kidney disease. What is the mechanism for the mineralocorticoid for cardiovascular and renal damage? When the condition started with either hyperkalemia or hypovolemia or the increase in the angiotensin II, all which stimulate the release of aldosterone from the zona glomerulosa in the adrenal gland. Aldosterone binds to mineralocorticoid receptor in different organs. The brain resulting in increased sympathetic nervous system activity, blood vessel resulting in the development endothelial dysfunction, decrease in nitric oxide, and fibrosis, both which share for the hypertension. When it binds to the mineralocorticoid receptor in the heart, it promotes the apoptosis, fibrosis, and the inflammation, which result in hypertension and heart failure. And when it binds to the mineralocorticoid receptor in the kidney, it results in several adverse renal events, of the most important saltwater retention, proteinuria, glomerular injury, all which result in the development of the CKD. So we need to block the mineralocorticoid receptor with several agents. We had several generations for the mineralocorticoid receptor antagonists. The first generation is the spironolactone, which has a lower selectivity as compared to the eplerenone, which has a medium to high selectivity for the mineralocorticoid receptor. And finally, the novel non-steroidal finerenone, which had a high selectivity. When we look for the adverse renal event, it is high for spironolactone as compared to the other two generations of mineralocorticoid. And all share a beneficial effect on the cardiovascular system in the reduction of mortality, hospitalization, reduction PMP, diastolic dysfunction, fibrosis, oxidative process, and atherosclerotic progression. But the novel non-steroidal finerenone is still questionable regarding its safety and its efficacy for cardiovascular protection. So finerenone is a novel non-steroidal mineralocorticoid receptor antagonist, being a bulky non-steroidal molecule, and it has a high selectivity and potency for mineralocorticoid receptor. It must, to address the safety and efficacy, we had the phase 2 program, ARTS diabetic nephropathy trial, which studied the effect of finerenone on albuminuria in patients with diabetic nephropathy. And according to the inclusion, it included patients with diabetes and high or very high albuminuria, duration of 3 months, potassium less than 4.8, and no previous use of spironolactone, eplerenone, potassium-sparing diuretic. What about the endpoint? The primary endpoint here is the urinary albumin creatinine ratio at 3 months versus baseline, and the other endpoint is the safety endpoint regarding the hyperkalemia or reduction in the estimated glomerular filtration rate. The ARTS diabetic nephropathy primary efficacy analysis show a dose-dependent reduction in the urinary albumin creatinine ratio with a dose ranging from 1.25 up to 20 milligrams. This regarding the efficacy. But what about the safety analysis? The safety analysis show a small change in the serum potassium with the wide range of the doses for the finerenone. So ARTS diabetes nephropathy concluded that there is a 30 to 40% reduction in urinary albumin creatinine ratio, systolic blood pressure reduction approximately 5 milligram in 10 to 25 millimeter mercury in 10 to 20 milligram finerenone, less frequency of hyperkalemia, and we can consider that this has been paved the road for the phase 3 studies to address the efficacy of finerenone in cardiorenal protection. Finerenone in chronic kidney disease phase 3 trials. There are two important landmark trials, one published in 2020, which is the FIGARO DKD trial, and the second that has been recently published in 2021 is the FIGARO DKD. Both trials share common similarities. Both trials are randomized, double-blind, placebo-controlled phase 3 trial. But the first difference here is in the endpoint. In the FIDELITY, it addresses the efficacy of finerenone on the progression of chronic kidney disease in patients with established diabetic kidney disease. But regarding the FIGARO, it addressed the efficacy of finerenone on reduction of the cardiovascular morbidity and mortality in patients with established diabetic kidney disease. What about the inclusion criteria? Post-trial recruited patients, male or female, more than or equal 18 years, subject with type 2 diabetes as defined by the American Diabetic Association, retreated with either ACE inhibitor or ARBs, serum potassium less than 4.8, and established diagnosis of chronic kidney disease in type 2 diabetes mellitus with either high or very high albuminuria. And here came the second difference between the two trials. In the FIGARO, we can appreciate here that it recruited patients with a less advanced form of kidney disease, including stage 1 and stage 2, as compared to the FIDELITY, which recruited patients with more advanced from stage 2 to stage 4 chronic kidney disease. What about the randomization? After run-in period and the screening period, the patient either randomized to finerenone 10 or 20 milligram, depending on the estimated glomerular filtration, versus the placebo. In the FIDELITY, they recruited 5,700 patients, while in the FIGARO, they recruited 7,300 patients. What about the result of the FIDELITY DKD trial? Regarding the primary composite, as we mentioned, which is the composite renal endpoints, there is statistically significant reduction in the primary composite endpoint in form of kidney failure, sustained decrease of the GFR by more than 40% from baseline, or death from renal cause. Okay, what about the secondary composite outcome, which is the cardiovascular outcome? It's statistically significantly low in the finerenone arm as compared to the placebo arm. This is regarding FIDELITY. What about the FIGARO DKD result? The primary composite endpoint here is different, as we mentioned, that it is the composite cardiovascular endpoints. It's statistically significantly low in the finerenone arm as compared to the placebo. And when we go for the individual endpoint analysis, we will find that this statistical significant reduction is brought mainly by the hospitalization for the heart failure. So for a conclusion regarding the FIDELITY and FIGARO DKD trial, in FIDELITY, the patient with established diabetic kidney disease, treatment with finerenone lowers the risk of chronic kidney disease progression and cardiovascular event as compared to placebo. Regarding FIGARO, among patients with type 2 diabetes with stage 2 to 4 with moderate elevated, and the patient, and this is very important, stage 1 or 2 with severely elevated albuminuria, finerenone improved the cardiovascular outcome as compared to placebo. And this will take us to a FIDELITY analysis. A FIDELITY is not a trial. It is a specified meta-analysis combining the data from FIDELITY and FIGARO DKD. What is the aim of this? It is important to evaluate the relation between the different stages of chronic kidney disease and efficacy of finerenone on the composite cardiovascular and renal endpoints. The FIDELITY analysis recruited more than 13,000 patients, with a primary endpoint is the composite cardiovascular endpoint in form of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, or hospitalization, similar to the FIGARO. Regarding the secondary endpoint, it is the time to the occurrence of the composite kidney failure or decrease of the estimated glomerular filtration rate by 57% or more. What about the result and the conclusion? Yes, finerenone reduced the risk of cardiovascular and kidney outcome as compared to the placebo across the spectrum of chronic kidney disease in patients with type 2 diabetes mellitus. And this cardiovascular benefit were consistent across the whole range of estimated glomerular filtration rate and urinary albumin-creatinine ratio categories. This is about the first section in our presentation. The next section carries a title, which is a major win against a formidable medical condition. What about the background? A patient with heart failure, as previously mentioned by my dear Professor Dr. Karim, can be classified either into a reduced or a preserved ejection fraction, with a cut-off point mentioned in the heart failure guidelines being the ejection fraction 50%. What about the pathophysiology for a patient with heart failure with preserved ejection fraction? Again, it is an interplay of different pathophysiology, including systemic inflammation, epicardial adipose tissue accumulation, coronary microcirculation rarefaction, myocardial fibrosis. All these result in vascular stiffness and impairment of the left ventricle relaxation. Up till now, as previously mentioned by Professor Dr. Karim, we had a limited evidence for the hard endpoint in management of patients with heart failure with preserved ejection fraction. And most of this endpoint came from a subgroup analysis in the Paragon heart failure, which addressed that reduction in heart failure in patients with estimated left ventricle ejection fraction less than 57%, but not more than this. And the TopCat American side, which show a reduction in the composite cardiovascular death and heart failure in patients with left ventricle ejection fraction less than 55%. And the DECLARE-TIMI show no reduction in a subgroup analysis of the heart failure outcomes in patients with heart failure with preserved ejection fraction. So the dedicated Emperor Preserved trial was carried to evaluate the effect of SGLT2 with empagliflozin on the major heart failure outcome in patients with heart failure with preserved ejection fraction. Improved preserved inclusion criteria. Improved preserved is a double-blind, randomized, placebo-controlled trial for addressing the efficacy of SGLT2 on the major heart failure outcome in patients with HFpEF. Regarding the primary endpoint is the composite of cardiovascular death and hospitalization for heart failure. But regarding the secondary endpoint is the occurrence of heart failure hospitalization, whether it is the first or the recurrent heart failure hospitalization. And secondary endpoint is the rate of decline in the estimated glomerular filtration rate during double-blind treatment. The improved preserved inclusion criteria were men or women, 18 years or older, New York Heart Association class 3 to 4, and the left ventricle ejection fraction more than 40%, and the required patient to have proBNP more than 300 if in sinus rhythm and more than 900 if the patient is in atrial fibrillation. Regarding the improved preserved study population, the patient after screening period up to 28 were randomized either to empagliflozin 10 milligram or to placebo, and the both arm carries 2,900 patients in every arm. What about the results for the improved preserved? It shows regarding the primary composite cardiovascular death and or heart failure hospitalization, there is a statistically significant decrease in this endpoint with the empagliflozin as compared to the placebo. And when we go for further analysis, we'll find that this endpoint came not from the cardiovascular death, it came from the hospitalization for heart failure. What about the secondary endpoints and secondary outcome? Regarding the total number of heart failure hospitalization or the estimated glomerular filtration rate decline, it is statistically significantly low in the empagliflozin arm as compared to placebo. But when we look for the composite renal outcome, it didn't show any statistical significant p-value. What about the improved preserved conclusion? They concluded that empagliflozin reduced the cardiovascular death or hospitalization for heart failure in patients with HFpEF. This benefit was consistent across the pre-specified ejection fraction subgroup and was seen in patients with or without diabetes. And this will take us to the last part in our presentation, which is the Emperor pooled analysis. Both Emperor preserved and Emperor reduced are two sister trials with many similarities, separated by an ejection fraction of 40%. So Emperor pooled was prospectively designed to assess the effect of empagliflozin in patients with heart failure, with the heart failure events being the primary outcome. They recruited 9,700 patients, with the primary endpoint being the heart failure outcome, and another endpoint is the major renal outcome. Regarding the heart failure hospitalization, we'll find that when the ejection fraction is less than 65, there is a 30% risk reduction for the heart failure hospitalization, whether this is the total hospitalization or the first heart failure hospitalization. But when the left ventricle ejection fraction is more than 65%, this statistical significance is lost. Another important point is that the ejection fraction influences the effect of empagliflozin on heart failure outcome. Here we can appreciate that ejection fraction less than 60%, there is a statistical significant reduction of the total heart failure hospitalization as compared to ejection fraction more than 60. And again, this ejection fraction influence affects the renal outcome. Looking here, we will find that left ventricle ejection fraction less than 60, there is a trend for statistical significant reduction in the renal endpoints with empagliflozin as compared to placebo, as compared to the patient who have left ventricle ejection fraction more than 60%. So the conclusion for the Emperor pool, the effect of empagliflozin to reduce heart failure outcome is highly concordant in both Emperor preserved and Emperor reduced. A risk reduction of 30% was maintained up to ejection fraction of 65%. Empagliflozin decreased the major renal outcome in Emperor reduced, but not in Emperor preserved. But when we used a more stringent criteria, which is the combining of the renal death and the reduction of estimated glomerular filtration rate by more than 57%, we'll find that ejection fraction influences the effect of empagliflozin on the major renal outcome. And thank you.
Thank you so much, dear Amr. these were two magnificent presentations for very important trials. And I have a question to you starting from the last trials on the SGLT2 inhibitors. The effects, it seems like that the SGLT2 behaves when they are needed most in diabetes and in heart failure. So in diabetes, if there is no hyperglycemia, they don't produce or decrease the blood glucose, causing a significant hypoglycemia. And that's showed repeatedly in all the SGLT2 inhibitors and heart failure, that when the ejection fraction is nearly normal, 60%, the effect of SGLT2 is decreased significantly. So what's your agreement about this statement that when it's not needed, this group tends not to work or to do its effect properly?
Yes, Dr. Haytham, when left ventricle ejection fraction is more than 60%, the empagliflozin, as been previously mentioned in the pooled analysis, it lost its effect on both heart failure and renal outcome. But when the left ventricle ejection fraction less than 60 to 65%, it had a great effect on both heart failure and renal outcome.
Okay. And regarding the MRAs, which is now one of the pillars of the treatment of heart failure, I think this is a relief to show that it's also safe in CKD patients. But do we have any relation in this trial between the degree of improvement of these patients regarding to the class of presentation, meaning that the MRA is more effective in early stage, like class 2 or 3 NIHA class, or that its effect is unified through all the classes of heart failure presentation, even class 4?
Okay, Dr. Haytham. Regarding the effect of finerenone, it has been addressed in the ARTS heart failure trial. I didn't mention it here because I am going to talk about the diabetic kidney disease. But in ARTS heart failure trial, it's a trial that shows the efficacy of the finerenone in the patient with different stages of heart failure. Not only it has an efficacy, but it had a lower risk as compared to spironolactone and eplerenone for the risk of hyperkalemia and acute adverse renal events.
Okay, so it's a class that any heart failure patient could benefit with, whether it's a mild heart failure or it's an advanced heart failure.
Yes.
Okay. Dr. Karim, Dr. Mohammed Zahran.
Thank you, Amr. Amazing as usual.
Thank you, Dr. Karim.
I'll ask you for some clarification rather than questions. So the finerenone as a new mineralocorticoid receptor antagonist agent, would you use it as the other mineralocorticoid receptor antagonist, or you are going to use it in a special subset of patients based on, of course, the previous trials?
According to the Fidelio and FIGARO, they illustrated that the patient with diabetic kidney disease either, and according to the Fidelity analysis, all the patients with chronic kidney disease with across the wide spectrum of estimated glomerular filtration rate show an efficacy regarding the cardiovascular and renal outcome. So it can be used in all these subgroup of patients with diabetic kidney disease and across the wide spectrum of estimated glomerular filtration rate, based on these two trials and the Fidelity analysis.
But regarding, did they include heart failure patients in these trials?
In these trials, they excluded the patient with heart failure with reduced ejection fraction.
So this is a prevention drug rather than a treatment drug. It needs to be studied like the other mineralocorticoid receptor antagonist, spironolactone and
Yes.
eplerenone, in the patient with heart failure with reduced ejection fraction to confirm its efficacy.
Yes, it is studied in the ARTS heart failure, but this trial is a phase 2 trial, and it has been considered in a small number of patients, and only for 1 month, not a long-term trial.
Okay, this is a very important point. Despite being these drugs has positive results, but this result doesn't mean that this drug is a heart failure drug,
Yes.
and we cannot include this drug into heart failure management right now. However, we can give this drug for prevention of the future cardiovascular events that can happen in these high-risk patients. Is this right, Amr?
Yes, Dr. Karim.
Okay. Another clarification regarding the empagliflozin. This was a very important trial, and you mentioned that ejection fraction in the subgroup analysis showed a little variation in the outcome when it compared between 40 to 50, 50 to 60, and 60. Do you have an explanation for this variation?
I think that the only explanation for this, Dr. Karim, is that they depend only on the continuous variable, which is the ejection fraction. And this ejection fraction shouldn't be considered the cutoff point for classification of the heart failure, being a continuous variable and an operator-dependent variable. This is maybe an explanation for this, Dr. Karim.
Okay, so I also believe that going up with the ejection fraction, all drugs now face a lot of difficulty in managing heart failure in this subcategory of patient. However, we will depend on the primary outcome of this trial, and I believe based on that, the coming guidelines would give a recommendation for giving these drugs in patients with mild reduced ejection fraction as well as HFpEF. Do you agree, Amr?
Yes, Dr. Karim.
So, is there a difference regarding the severity of heart failure in EMBER-preserved trial? So, if the patient have NIHA class 2 or NIHA class 3 to 4, is there a difference between these subgroups in using empagliflozin?
Empagliflozin show a statistical significant reduction in the total heart failure hospitalization across the all pre-specified subgroup analysis, whether those patients are diabetic or non-diabetic, and across a wide range of the New York Heart Association classification. It didn't show a reduction in the cardiovascular deaths, but it showed a reduction in the heart failure hospitalization.
Okay. And regarding the patient with chronic kidney disease, now we have the DABA-CKD with that showed a good outcome with dapagliflozin in the patient with chronic kidney disease. What is the impact of GFR and chronic kidney disease on this population as compared, of course, with other patients with the DABA-CKD?
ممكن نعيد تاني معلش السؤال دكتور كريم؟
So, what is the impact of chronic kidney disease on the outcome in the EMBER-preserved?
Okay, Dr. Karim. As we previously mentioned, again, that according to the subgroup analysis, we know that empagliflozin can be used up to an estimated glomerular filtration rate 20 milliliter. Empagliflozin above 20 milliliter, estimated glomerular filtration rate above 20 milliliter, has been associated with statistical significant reduction in the composite endpoints, cardiovascular death and heart failure hospitalization, again driven by the reduction in the heart failure hospitalization.
So I believe, thank you, Amr. All of these are clarification rather than questions to orient ourselves with the complete result of this very important trial. I thank you again. This illustration was amazing, as usual, Amr. And I think we are waiting for more presentation from you in the future, dear friend.
Okay, thank you, Dr. Karim. Thank you so much. Thank you, Dr. Haitham. Thank you, Dr. Mohammed Zahran.
So back to Haitham and Mohammed for wrap up.
Thank you, dear Amr, and thank you, Karim. Dr. Mohammed, are you with us?
I think you can go with the wrap up, Haitham.
Okay.
Yes, Haitham, I'm there. Thank you so much. I'm sorry for being busy tonight, but you can wrap up the session. Thanks a lot, Haitham. Thanks a lot, Karim, for the wonderful illustration. For the wonderful presentation of those mega trials. Thanks a lot. Haitham, you may wrap up the session.
So thank you so much. We had a very, very important night in the sessions of the European Society of Cardiology guidelines and late-breaking trials regarding the heart failure. Dr. Karim showed us very elegantly the new algorithms that classify heart failure, classify acute heart failure, the new recommendations for drugs in treating the various types of heart failure, whether reduced, mildly reduced, or preserved ejection fraction, the new concepts or the concepts highlighted into the rehabilitation of the patient, the treatment of comorbidities, which is very important, and the entities of cardiomyopathy elegantly showed the amyloidosis. Then Dr. Amr dazzled us with the explanation of two important trials. One of them is the new MRA that is very good for prevention, and we are waiting for more data for treatment or the actual treatment of heart failure itself. And the other is of the rising group of SGLT2 inhibitors, the empagliflozin and its effects on heart failure and its effects on the heart failure with preserved ejection fraction and on eGFR and the renal functions in diabetic and non-diabetic patients suffering from heart failure. So I thank you all and wishing to see you in the other nights of the European Society of Cardiology. We have a very important night next week concerning the prevention guidelines. So stay tuned until we meet again. Thank you so much.